So tonight we're going to have a look at the liver pathway. It's a fairly daunting process for 10 minutes. When I get liver function tests back, I try and look at them, decide is it cholestatic or is it hepatitis, hepatitic-like picture. If it's cholestatic, it's going to be dominated by ALP phos gamma GT, and the bilirubin, if it's up, would be conjugated. And if you see that picture, then you need to get an ultrasound to make sure there's no problems with the ducts. What we're going to look at tonight is a hepatitis-like picture dominated by AST and ALT, and less so for the ALP phos and gamma GT. And if the bilirubin's up, it would be a mixed picture. And on the pathway, it lists hepatitis B, hepatitis C, fatty liver as part of this. But tonight, at a time, we won't be covering fatty liver at all. So for hepatitis B, the screening test is the hepatitis B surface antigen. There's two coats on the hepatitis B virus. There's the surface antigen, the core antigen, and the DNA in the centre. And the screening test is to this surface coat here. Now, the protective antibodies that you get is the surface antibody, and that's an antibody against this coat here. And if a vaccine, you get a surface antibody only. If you've had a native infection, you get immunity, and you get a surface antibody and a core antibody. So that's how you distinguish between the two. Right, so on the pathway, your first screening test, hepatitis B surface antigen. Well, what do we do next if you found that? Well, the next thing on the pathway, hepatitis B e antigen. So what does hepatitis B e antigen mean? I like to think about three types of hepatitis B. There's acute hepatitis B, and this is a picture you get. You start off e antigen positive, and you'll also have IgM core antibody positive. So you get an IgM, which is always the first antibody against the core, and the E antigen positive. That tells you it's acute hepatitis B. We're not covering acute hepatitis B tonight. If you've got adult acquisition, in other words, in a competent immune system, you usually get over it in 3 months. Then the chronic hepatitis B is mainly people who have a poor immune system, or the vertical transmission that's mainly seen in Southeast Asia. So these people are E antigen positive and they haven't got over the infection. So, first case, 36-year-old from Vietnam, E antigen positive, but no E antibodies, haven't seroconverted. The DNA is high. So if you're E antigen positive, you're replicating and you'll have a high DNA. But look here, you've got high transaminase enzymes. So here's the danger signs of the patient that we need to see. Right. So this is the patient with E antigen positive on the pathway. Refer them with high transaminases and high DNA. So what happens with the E antigen status of the patient? These are people that haven't got over their acute attack. You go through an immune tolerance phase where your DNA is high, your ALT is normal, your surface antigen positive, your E antigen positive, and you haven't made this E antibody. And at some time the immune system kicks in. It's not the virus that destroys your liver, it's your immune system trying to clear liver cells that are expressing the virus on the surface. So the immune system has an attack here and it manages to clear the virus. So we go from E antigen to E antibody, and see now we're E antibody positive, the DNA's dropped, the ALT's become normal, and you go into this quiescent state. That's what you hope will happen, a nice clean seroconversion. But not everyone does that. So what happens with some people, they have lots of attempts here of the immune system trying to clear the virus. So you get these peaks in the ALT. So you remain surface antigen positive, your E's positive right through here, and it's not till down here that finally the seroconversion occurs. But as you go through this process of all these flares, that's how you're scarring your liver, and you'll end up going from a normal liver at this end to a cirrhotic liver. So that's why you're wanting to treat the E antigen positives with these high transaminases. Right, case number 2, 35-year-old. Now we're E antigen negative. We've got the seroconverted to the E antibody. The HBV DNA is not detected. ALT is consistently normal. Little virus, no inflammation, not a problem. So that's the so-called inactive carrier, and probably can be monitored in general practice. Quite different. Right, hepatitis C virus. It's an RNA virus. Unfortunately, most people don't resolve it and they go chronic. It's diagnosed by the antibody. It used to be the PCR, but it now comes back as a titer, in other words, the viral load. And then we look at the genotype, because your treatment depends on whether you're a 2 or 3 or a 1. And often the Hep Cs will have mildly fluctuating abnormal liver function tests. What do you do if the patient has normal liver function tests? So they're C antibody positive, PCR positive with a reasonable titer, but the liver function tests remain normal. Well, we used to not worry about them, but then there was a study done looking at patients with elevated ALT, biopsying them, and you can see 22%, 38% had significant fibrosis, but even in the normal ALT group, 12% had significant scarring of the liver. So a normal ALT doesn't necessarily mean things are okay. And why is that important? Because with the treatment, if you're F0 with no fibrosis, this is the genotype 1, you've got a 68% response. By the time you're cirrhotic, your response rate to treatment is 6%. No good doing it there. Got to treat early. How did we know whether you got cirrhosis or advanced fibrosis? Well, we used to do a liver biopsy where you could grade inflammation, stage the fibrosis, and it usually takes about 5 to 8 years to go through each of these 1, 2, 3, 4 stages. But a liver biopsy is not essential for getting hepatitis C treatment now. So what are the clues in your surgery that a person may have significant liver disease or fibrosis? Well, the platelet count falls, because if you get cirrhosis, you get portal hypertension, your spleen enlarges, and you can consume platelets, red cells, and maybe leukocytes. But that's one that we most notice falls first. The INR might go prolonged. The albumin falls, and originally we had ALT higher than AST. Once you get cirrhosis, it switches round. Your AST becomes higher than the ALT. The only other situation you'll find that is alcoholic hepatitis, where you're not necessarily any fibrosis. That's the one disease where you get reversal of the ratio. But normally, in all other diseases, that's indicating that they've gone on to cirrhosis. Right, what's new in liver disease? Well, this is the new FibroScan, and that's a non-invasive test for staging fibrosis, and it generates a pulse wave which gives a measure of liver stiffness, and it's like whether you've got a spongy ball or a cricket ball. So that's what the scan looks like. It cost $120,000. We've only just got it. There's the probe here, and you get it, try and get it between the ribs so that you're not getting muscle or rib. And you've got an ultrasound there that tells you whether you're firing on the liver, and you put 10 pulses through to tell you whether it's a sponge ball or a cricket ball, and you average those scores, and that gives you an indicator of fibrosis. It's well validated for Hep C. It's not so good for fatty liver, not so good for hepatitis B, unfortunately. And it's not linear. It's very good telling you there's no fibrosis or you're cirrhotic, but it would have difficulty distinguishing a 2 and 3. But it's very useful. You can monitor your patients over time. How long does it take? About probably 15, 20 minutes. And you want a low score. Right, treatment for hepatitis C. This is the current treatment with the PEG interferon and ribavirin. You can see your response rate is very genotype dependent. If you fail treatment, is it any use treating again? Well, there's 52% response for naive patients. If you've had non-responder to the standard interferon or standard interferon and ribavirin, may be worthwhile, but it's no good if you've had PEG interferon and ribavirin. Waste time doing it again. So what are you going to do if you failed treatment? Well, coming on stream, we've got a lot of DAAs or direct-acting antivirals, and the protease inhibitors, there's trials on at the moment with those. There's one with telaprevir at the moment. They require PEG interferon ribavirin and the protease inhibitor, and it's not very good for genotypes 2 and 3. But the newer generations will be better for that. This one's looking the most promising, and there's one from Pharmaset now that you take 1 pill a day for 3 months, and it looks like exciting results. So if you're genotype 1 and had low fibrosis score, would you take peg interferon and ribavirin? Now, I probably wouldn't. I'd be waiting for one of these. It might take 3 to 5 years, but it might be worth it. So if you fail treatment and you've got cirrhosis, we still have to screen for portal hypertension. That applies to whatever your cause of cirrhosis is, because you need an endoscopy to look for varices, and you go on a non-selective beta blocker like nadolol or propranolol, and you need an ultrasound annually, an alpha-fetoprotein 6 monthly to look for evidence of for HCC or hepatocellular cancer. It's dominated, hepatocellular cancer is males and cirrhosis. And nutrition is very important in patients with cirrhosis. It's a catabolic state, and overnight they often get low in nutrition, and it's often worth having something like Fortisip or one of the nutritional supplements at bedtime to keep the nutrition up.